Okay, so I am Frances Russell. I'm one of the ultrasound faculty at Indiana University.
I'm Laura O. I'm from Emory University.
Lawrence Melniker from New York Presbyterian Brooklyn Methodist.
Stephanie DeMasi from Vanderbilt University Medical Center.
Mike Rush in Chicago.
Leonard Polo from John Peter Smith Hospital in Fort Worth, Texas.
I'm Yo-Yo Dwamu from Stanford University.
So as many of you know, we normally do our SAMES presentation, which is our ultrasound awards, during the annual business meeting, but because we've kind of condensed that down, we wanted to do a separate didactic. And really, one of our goals of this presentation is to try to find ways to improve the quality of research that's coming out for point-of-care ultrasound. We do have a few disclosures that are listed up here. So point-of-care ultrasound and point-of-care ultrasound research has been around for a long time. When it originally started, we kind of had those questions of, can we use ultrasound to make a diagnosis? And what we found for a majority of the cases is yes. But we kind of need to progress from there. And we've done a fairly good job of doing that, asking questions like, how will this ultrasound improve outcomes for patients? How will this ultrasound change my treatment to improve care or comfort for a patient? So we're going to talk about a few articles that fit into these different types of studies, so observational, interventional, medical education, systematic reviews, and broad-scale innovation. We're going to talk about key kind of concepts or take-home points from each article. We'll talk about limitations, and then just on taking a broad stroke of articles that are published within each of these categories, best practices, as well as things that we can do to improve our research. And I'll let Laura take it away. Stand up.
I must stand. Okay, so one of the most influential papers to come out of the last year that was an observational study was produced by Megan Leo et al. This is using deep learning to detect the presence and location of hemoperitoneum in FAST exam in adults. So this study took place at a level 1 trauma center from 2010 to 2018. It was a retrospective analysis of adult FAST exams performed by emergency physicians. There were 44 cases of hemoperitoneum and 50 negative controls. And the positive exams were confirmed with CT or operative report. So there were 2 POCUS experts, and they analyzed the right upper quadrant views only to establish ground truth labels for free fluid, for a free fluid detection algorithm. The algorithm they used was YOLO v3, a deep learning algorithm, and the model was evaluated and developed using a 5-fold cross validation. This is typical in machine learning studies. So 94 cases were partitioned into 5 folds. 72% of the cases were used to train the algorithm, 8% of cases were used for validation, and 20% of cases were held out for testing. YOLO v3 performed exceptionally well, 95% sensitivity, 94% specificity, 95% accuracy, and 97% area under the curve over the test set, which was significantly better than previous methods. It exhibited strength in localization, the image processing was quick, and it could be performed at the bedside on a laptop or a smartphone. So limitations. So it's unclear why there are only 44 positive exams over an 8-year period in a trauma center that saw 140,000 visits a year. So were these the only high-quality images that were available, or were they somehow selected for in a certain way? Reading between the lines, it seems like this trauma center perhaps had a lot of phantom scanning, right? Like similar to all our trauma centers. So people, it's not a unique experience. So people don't record images because they're negative. it's a poor quality image. Maybe the patient's body habitus prevents a good image. Maybe there's something emergent where the patient is going to OR. And so I suspect that this is a phantom scanning issue. But if the algorithm doesn't see all the possible comers, it's less good when it comes to actually meeting, difficult patients in real life. So other limitations, I think because there was such a small sample of positive cases, they used a 1-to-1 ratio of positive to negative cases. This causes a distributional shift because in the real world, you're not going to have a 50% positive rate. The other limitation to the study was only looking at the right upper quadrant view. So as you know, right upper quadrant view is easier to get than the left upper quadrant view or the pelvis views. Perhaps the algorithm sensitivity or specificity would have been negatively impacted if all views were included. So the best practices for observational studies can be found on the Equator Network. And there are very specific guidelines for machine learning studies in particular. So if you're interested, go to the Equator Network to check out what the best practices are for doing machine learning studies and also observational studies more broadly. The key take-home point, deep learning algorithms can ID the presence and location of blood in the abdomen with high sensitivity and specificity, and this can assist novice clinicians in making a diagnosis at bedside. What wasn't mentioned in the paper, but is also very cool, is a consideration that if YOLO v3 and other deep learning algorithms perform this well, it's potential you could offload faculty QA. So that's an also exciting application. Yeah, hands over. So AI is a fascinating new area of emergency ultrasound research, and kudos to these authors for producing one of the best papers of the year.
Okay. I'm a little biased. Next, I'm going to talk about my study. And one thing I didn't mention at the beginning is we chose individual studies from a short list of the top studies in each category, but these are not necessarily the winners of the SAMES Awards, and those will be announced during the business meeting tomorrow. So this was a study on pre-hospital lung ultrasound, looking at patients with acute heart failure. I essentially, with my study team, trained 26 paramedics, and they used a 2 to 4 view scanning protocol. So essentially, they took patients who were being transported to the hospital with shortness of breath. There were adults, and they performed lung ultrasound, looking in the anterior, superior lung zones. If those are positive for greater than 2 B lines, that on each side, then they were done. If it was negative on any side, then they would go down and look at the corresponding zone 4. And if they found bilateral B lines, then they followed the heart failure or pulmonary edema treatment pathway. And the great thing about pre-hospital lung or pre-hospital ultrasound is you can pretty much track patients consecutively. So we looked at 353 patients with shortness of breath. 89 were excluded, and of those, 40 patients had a lung ultrasound. 94% of the patients, or 94 patients, or about 35%, had acute heart failure. And what you can see here is that from, I don't know how to use this. Okay, sensitivity without lung ultrasound was only 23%. Specificity was very high at 97. And with the use of lung ultrasound, sensitivity improved to 71% and specificity stayed about the same. So we were able to improve sensitivity, accuracy, and importantly, we were also able to change management in these patients, where you can see here that more patients received pre-hospital nitroglycerin, and that was statistically significant. So these were paramedics doing the ultrasound, interpreting the ultrasound, and then changing treatment based on what they were finding. We also found that we were able to start treatment over 2 hours earlier in patients with ultrasound compared to those without. So limitations of this study, it was a single agency, it was a relatively small sample of patients that received ultrasound. There was some selection bias, so not all paramedics used ultrasound, and they appeared to pick and choose who actually got the ultrasound. Here, 52 patients that met inclusion criteria and should have received an ultrasound as a trained paramedic was transporting them did not get an ultrasound. And also, this was not a randomized study. It was an interventional study in that we compared patients with and without ultrasound, but it was not randomized. So take-home points from this study is we can train paramedics to do this. They can increase their diagnostic accuracy for being able to detect heart failure. And by use of ultrasound, they can increase rates of heart failure treatment and significantly decrease time to treatment.
All right, so I'm going to briefly talk about limitations, thank you, of randomized controlled trial in the space of point-of-care ultrasound. And what was so striking about the SAMES Awards, the top 4 articles that we voted for, was the dearth of RCTs themselves in the space of point-of-care ultrasound. There were 2 that were cadaver studies, so by definition, they would not meet criteria to be integrated into our guidelines because they weren't human subjects research, and 2 were observational studies, so they did not have randomization, and we'll talk about whether that was a limitation or not. So why is there such a void of RCTs in this tool? We can break it down in 2 buckets. There are design challenges and there are conduct challenges. In general, there are 4 types of randomized controlled trials. There are diagnostic studies that ask the question, does the patient have this condition right now? There are prognostic studies. Will the patient develop this disease process later? Etiologic, did exposure of this variable cause the outcome? And then interventional, which is sort of the classic RCT, will assigning this patient to this treatment affect this outcome? Point-of-care ultrasound, rather than sort of the classic interventional RCT, is most commonly used as a diagnostic tool. And there are challenges when doing or designing diagnostic RCTs. If you're just looking at diagnostic accuracy, like Francis did, including randomization actually doesn't add much to the methodology of your study. So it was an appropriate trial design, and I would argue that it wasn't a limitation in her study. However, if we want to analyze whether your diagnostic tool affect patient outcomes, there are important aspects in the trial design. You need the performance of the diagnostic test as your afferent arm, and you need how clinicians change their care because of that test, the efferent arm. And these 2 have to connect. The most frequent mistake that we see in diagnostic RCTs is that the performance of the diagnostic test actually didn't change clinician care, and essentially it's a null RCT. But we know point-of-care ultrasound changes what we do. We just have to make sure that we measure it in our trials. And conduct challenges. We have to teach a protocol, which some are more difficult than others. Users have to be confident in their performance of the ultrasound and their ability to interpret it at the bedside. We have to enroll beyond just most of us ourselves to maximize our generalizability. And then funding. This is an expensive tool, and it costs money to do these trials. But despite both the design challenges and the conduct challenges, we can and will design RCTs that will support this essential tool in emergency medicine.
So some of the best practices, we talked about this last year at the SAMEs, in that interventional studies, randomized control studies, they're just hard to do in ultrasound because of all the things that Stephanie just mentioned. And so we have the least amount of studies coming out in ultrasound that would fall into this category. And so some of the things we need to consider when you're doing a study like this is obviously following the Equator guidelines. So when you're designing it, when you're reporting on it. And then you ultimately have to figure out what is feasible for you. So is doing a large randomized control study even feasible? You probably need to get funding. Romulo can probably speak to the funding aspect. So it can be very challenging. And then what are you looking at? What are the outcomes? We definitely need a lot more data in the ultrasound space in terms of, okay, I can make this diagnosis. Are people changing their care? But is this truly impacting outcomes? Does it matter? Do I need to be teaching on this because will it even change things ultimately for the patient, which is what we care about. If you were at the plenaries this morning, this is one of the methodology that they used, which I think is great because this is a stepped wedge randomization controlled trial design. So essentially, you have patients starting off in a control period and then, or for example, for me, it would be an ambulance. And then you slowly have people change into the intervention period. It's similar to a before and after, but actually counts as a randomized control trial. And I think it would be perfect in ultrasound because you can turn on the intervention or teach people ultrasound, but you don't have to do it all at one point in time. You can kind of space it out. So really, kind of for the individual designing their study or implementing a study, you really have to think about what works for you. And then collaborating. There's a lot of people doing very similar type of research out there. And so finding people either through listservs or the collaborator connection that SAEM offers in terms of how to increase the N in your study, the power in your study, so you're able to look at some more clinically relevant outcomes.
Present at the same time.
All right, I guess I can start us off. Hey, everyone. All right, so we're presenting our choice of the education paper for POCUS this year. And this is a study named Tool to Assess Competence in Critical Care Ultrasound Based on Entrustable Professional Activities. And it was a paper that came out with a collaboration between critical care groups and then also Rachel Liu from Yale, who is our ED POCUS representative. And so this study also was funded, which I thought was really interesting because a lot of times it's hard to get POCUS funding and hard to get education funding, but it was part of a T32 NIH grant through the NHLBI. So as we know, there's a lot of different ways that we assess our learners in POCUS. This is a table that was modified from Dr. Damewood, and it kind of shows some of the things that most of us have probably tried at some point, giving them written tests, doing OSCEs, which can take, an hour or so per learner, SDOTs, and then of course QA image review. All these have pros and cons, but a newer type of assessment model that's been introduced in medical education are EPAs, which is part of competency-based medical education. And one pro about EPAs is that it's done in parallel with clinical work. And so basically, a trainee will do a certain activity with a supervisor, and then at the end of their shift or at the end of that session, they will be evaluated on one of a certain list of entrustable professional activities. And the goal is that all the trainees will get to being able to practice independently and do that activity safely by the end of their training. And so that is a nice framework that is being proposed in different aspects of medical education. And then this is the first one that we've seen where it was used for point-of-care ultrasound education.
Which is why,
Oh, sorry, here.
my high voice doesn't carry long distances. So this is why we chose it, because we've been hearing about these EPAs, but we didn't actually see anything related to ultrasound. So the objective for this study is to design an EPA-based tool to assess competence in critical care ultrasound for pulmonary and critical care fellows, and to assess the validity and reliability of such a tool. So the methods, briefly, is what was interesting is they did this nominal group technique, and they used that to develop core EPAs. Oops, go back. The core EPAs, we'll see on the next slide. And then they used this assessment tool to, they wanted to validate it. And so they had their learners self-assess themselves. And then they also had their trainers or their faculty do the same evaluation on them shortly after. And then 3, 4, and 5, I'm not going to go into detail because it's a lot of the validity testing. And so I think after reading a lot of these assessment tools for validity, what we gained from it is that if you're going to do an educational research study, get somebody on your team that knows educational research and a lot of kind of the sophisticated statistics that go along with it, because they so eloquently described it in their paper. It was very impressive, but we didn't understand truly what it meant. We kind of do, I think, and we even talked to one of the authors who talked to the lead author, and I don't know if they actually understood some of the things that they went through. So anyway, it's not a criticism of the paper, but it's really just kind of, I guess, kudos to medical education research. All right, next slide. So what is the nominal group technique? And just want to take you through this. I've never heard of this, but it's really interesting, kind of streamlining getting consensus on something you want to study that doesn't already exist. So you need a team leader who kind of does the introduction, who kind of gets everybody involved, selects their team, who has this period of silent idea generation. So this is something that they do before they meet so that people aren't inhibited of, sharing their thoughts. Because, in some meetings, there's always somebody that dominates it. So everybody gets their kind of share of ideas, if you will. And then they actually, at the meeting, they share those ideas and have an open forum discussion. And then they have a debate. That's stage 4. It says group discussion, but it's more like a debate. And then they come up with certain items that they vote on, and then that becomes their assessment tool or whatever they're studying. But for this study, it became their assessment tool, which we'll see on the next page or next slide. So these are the core EPAs for critical care ultrasound that they came up with, which I think by face validity, looking at it, these are things that I would want to know from my trainee, that they know how to evaluate a patient with shortness of breath, hypotension, shock, cardiac arrest, sort of thing, and then the key procedures in these patients, central line placement, et cetera. So get your phones out, if you will, and just open their actual assessment tool, which took a lot of Googling. I found it, and I thought, this is kind of cool. I put my name in as the trainee. I put our fellowship director as the evaluator, and I was just clicking all these buttons just to see what would happen. And then I clicked submit, and it said, thank you for your response. And so I don't know where that went. So just so you see it, though, I like it because it's very easy to use. You can pull it up on your phone, and it takes you less than a minute to complete. And so the trainee did this on themselves, and then it was kind of initiated by them, and they did get a gift card for the most, if they got a certain number of evaluations, and then they gave it to their evaluator. So these are the assessments that they did performed by the trainee. So they didn't only do fellows. I think they wanted more numbers, and so they included some of the rotators. So they have residents that rotate for a month, but then their fellows are every single month. So you can see that they had a lot more of these assessments. Then you can see kind of in the middle which ones they did, because when you open that assessment tool, you can kind of choose which assessment you want to make. And then at the bottom, this is kind of something that they use. It's an entrustment, a modified Ottawa entrustment scale, if you will. So at the top, this is I did it, meaning the faculty did it. So the learner was completely not independent, and goes all the way to the bottom, which is where we want our trainees to be. And then here's just some of their data. This is an unadjusted linear regression model for their EPAs to these different factors. And then when they adjusted for it, the only thing that really stood out was the number of times a trainee has done the EPA. And, I think that kind of makes sense. I don't know if it adds anything to what we could imagine, because their fellows are there every single month. They're submitting more. They're more experienced. And so, of course, their scoring was probably a lot higher. So the key findings were mainly the creation of this tool, which I think is something that I'd like to see more of. It's very interesting. We might be able to use it in our practice or for future studies when you're reviewing a study. You're thinking about how you could do better. And then the only independent variable was what I had just mentioned. So key findings and limitations, actually. So single institution, kind of the similar limitations that we see in many studies: small sample size, trainee limitations. It was a very heterogeneous group. They gave some gift cards as an incentive, of course, and then there was, just influences from the clinical environment. We've all evaluated residents and medical students, and, there's just, sometimes they give you that evaluation when you're super busy, and so who knows how the clinical context was, and this is something that's done like right then and there. It's not something that you can like, can you email this, and those kind of things. The evaluation was completed in real time. There were multiple faculty, and a third of the faculty only completed one, and a third of the trainees only initiated one EPA. The biggest thing, I think, and I think this could have been really awesome if they did inter-rater reliability. Well, how would you do that in the critical care environment? You can't just like have two people observe them, right? So just thinking about maybe you could have done it in a simulated environment with a few different scenarios, videotape them, and had two evaluators independently review them as a thought, and then you could validate that your tool is measuring what you wanted it to do. And then just as we know, just the ED is kind of chaotic. Would we be able to actually replicate it? But I think it's an easy tool that we can complete quickly. So if we did do any evaluations in the emergency department successfully, this would be kind of something that might be helpful.
All right, and so wrapping up some best practices for education research, our main takeaways were that, as POCUS experts, we are all educators, and I think there's a lot of potential here for POCUS education research to embrace these validated education methods, including these up-and-coming methods like competency-based medical education and EPAs. And then sort of a subset of this study, but I think would be useful for other education studies, is using this nominal group technique to come to consensus among experts. Because a lot of times a big part of education research is like, how are we going to agree on what type of curriculum we're going to be teaching, or maybe go through a Delphi method that takes like back and forth over weeks or months. But this was a nice technique to come to consensus quickly. And then the other takeaway was that this type of EPA framework, which has been introduced in other types of med ed, it really worked well for ultrasound, because ultrasound is such a multimodal skill with a lot of different sub-competencies, and so EPA's worked well to kind of break out those sub-competencies so you can evaluate people in a lot of different types of POCUS. And so we think that the validity shown for EPAs in critical care ultrasound could be studied in other POCUS settings. And this is the final takeaway point, which kind of summarizes that graduate medical education has been focused on the competency-based framework, and ultrasound educators could adopt this to better assess our learners.
All right, so I'm going to start with a question. How many people here have published a paper on individual patient meta-analyses? All right, let's step back. Let's say, how many people have published a systematic review of any type? Let's go hands super high. All right. How many people have peer-reviewed a systematic review, where you've been asked to do it? How many people have read a systematic review? I think most people have probably read one, right? And we see this, and it's common. In fact, this is often what's used as like guideline established goal of, when we're trying to say, yeah, this is really good evidence. But is it? And so we chose this one, and my conflict of interest, I am one of the authors on the study, but mostly because I want to dissect it out for two reasons. One, to talk more about POCUS for SBO, because there is pretty good data, and it's a good idea to know about this data, but also to break out a little bit about how we do systematic reviews and how we understand them. So you can get double benefit, the science and the knowledge. So as we break it out, first thing, this is a systematic review with an individual patient meta-analysis. Basically what that means is a typical systematic review, they take all their studies, they take their summative amount of information, and they meta-analyze it, they combine it together, they give you this kind of summative assessment. And that's great when everything is identical. When everything is completely homogeneous and perfectly lined up, yeah, that seems like a pretty good model. Is ultrasound that way? Absolutely not. We have way too much heterogeneity in there. There's a big difference between the medical student versus the mid-year resident versus the ultrasound fellowship trained faculty member. And that has a wide range of impact. There's a difference between our patient population. There's a difference between scanning protocols. And so when we try to combine them together down one line, it's not surprising that the data is hard to use. Because we're like, well, it's really heterogeneous. That's the fancy term we use when data just doesn't line up very well. And so I'm saying, well, now what do I do with this? And that's what prompted the individual patient meta-analysis to say, all right, let's actually dissect this out and try to analyze this at the patient level, almost as if we were replicating this as one single study, instead of going and looking at it as a summative of a bunch of different studies. So they did a systematic review meta-analysis with individual patient level data. The inclusion criteria here had to be prospective, so it had to look at people going forward, not just saved studies, had to include adult ED patients. It was performed by emergency physicians, so we also narrowed it down. We said, that's great that we have these studies of radiologists or of cardiologists, some reason doing this. But if you look at it, you're like, I want to know about ED physicians. It's going to narrow it down to my population. And we had to have original data. And the reason we wanted original data was to say, number one, do the study protocols line up? Number two, who's doing it? Can we break it out by specifically residents versus attendings? And what does the patient population look like? And for this study, we broke it out by BMI. Do patients with a BMI over 30 versus less than 30? Does that make a difference? Because we've scanned people, and when you're looking at the belly, that may or may not influence it. We should know that going into it to figure out how we're going to apply this test. As we're going to talk about, but best practices when you're doing systematic reviews, and so when you're doing these as a reviewer or as someone who's going to be conducting these, everything's done in duplicate. You're screening with 2 people, you're extracting data with 2 people, and the reason behind this is if you have one person, it's just high risk of bias. I'm clicking through 400, 500 studies, I get really tired, my eyes blink, I miss a study and I exclude it, right? Or, I don't know about this one, we got enough studies already, right? All these factors that can influence it, but with 2 people, you start to reduce that risk because that means 2 people have to blink at the exact same study at the same time to have it come out by error. It means that 2 people are going to assess that, so you're more likely to not miss stuff. Same thing with extraction of data. A typo it's a lot less likely across 2 different people than against 1 person. They also design called quality assessment. Quality assessment or risk of bias assessment is basically telling you how good are these data. If the data is all poor quality, it doesn't matter the studies don't line up well because the problems with the studies in the first place. So they did Quadis 2. It's just a tool that you can use to assess the quality of the data. These are the kind of summative findings. So out of 486 screened studies, 5 studies were included. These 5, which include 433 total patients, are based upon those that not only met the inclusion criteria, but had to have the individual data available. So there are studies that exist out there that, there was one, for example, the authors just didn't have the data. So we couldn't include it naturally in that type of a study. But we had it for everyone else that came across there. We found overall the sensitivity was 83%. Specificity was 93%, which is pretty good when you consider ultrasound. When we broke it out by resident versus faculty, you can see that the faculty have a higher sensitivity at 88% and a slightly specificity of 91%. And then when you break it out by BMI, you can see again that there's a better sensitivity in the lower BMI, but actually a slightly higher specificity in the higher BMI. So there is something that seems to be occurring across these groups. As far as limitations go, so this is an ED-based study. It may not apply to other areas of POCUS. So we see this internal medicine floors, general surgeons, others. They're going to have different training. They may have different test characteristics. We're limited to those who had the data. So it ended up being only 5 studies, 433 patients, but still had pretty good amounts of data. There are some differences still that can be existing in there. When we categorize as residents, we know in our experience that those who are soon-to-be residents, who are residents and who train residents, that there's a big difference between the first year of residency when you first start out and you're first learning ultrasound and the person who's going to ultrasound fellowship who has 1,600 scans by the end of their training. It's just a different spectrum. So we can't really group people totally in there, but it gives a little bit better of a split out than we have a baseline. And then overall small total N. That said, outside of the main study findings, a couple best practices for those who are going to be reviewing, reading, interpreting, or performing these. First, there's guidelines called PRISMA. So earlier on, I believe Francis put up there for the Equator guidelines. We have, if you Google Equator, it has guidelines for like every type of study. So if you're ever curious of like, what do I need to do to have a high quality study? Just type Equator, and immediately you'll see it has a guideline that says exactly what you should do. So they follow PRISMA, and it kind of breaks down the specific types of things you should do at each step of the way. They use multiple databases, so they make sure they're more inclusive of studies. They try to ensure that patients had relatively similar protocols, so you weren't assessing one with SBO that had a threshold of 2.5 centimeters diameter, and another one had like a threshold of 3. So they kept them as relatively homogeneous, all had 2.5 centimeters diameter. They dual assessed, as I mentioned, and then they conducted the individual patient meta-analysis to try to account for some of those variations across those groups. Key take on what point of this is POCUS has pretty high specificity and relatively moderate sensitivity in the context of this, but as we saw, more studies are needed, and we really need to delineate it out a little bit further across some of these groups.
Hi, I'm Josh Davis. I'm a ER physician in Wichita, Kansas. I get to talk to you. We're all done with all the dry statistics and methodology. I get to talk to you about the cool, sexy innovation, just Koniyaku jelly, a quick preparation and cost-effective ultrasound-guided IV phantom model by Tanigawa et al. So this is one of our really cool innovation studies that we have that I'm really excited. The first question is what the heck is Koniyaku jelly? Well, it happens to be yam cakes or konjac, which is devil's tongue. Some of you may be familiar with this. It's a relative of the yam plant that they use in Japanese culture. They process it and they make it into this really ugly jelly. But apparently it tastes really good. And it is not related to cognac, which is the drink, if you're confused. So why would you do such a silly thing? Why do we need to make a phantom model out of this weird jelly that nobody's ever heard of? Well, the first thing would be cost, right? So you can go buy a blue phantom if you'd like, but those are several $100s and you still have to replace them every couple years. Time. So if you've tried any of these other methods to make some of these ultrasound phantom models, it can take a lot of time to do it. And the third one, which is very relevant to this particular study, is the mess that it makes in your kitchen. So when I was a medical student, one of the authors on this study, Arthur Au, I actually went to his house and we made gelatin and Metamucil ultrasound phantoms in his brand new kitchen. And he years later was texting me about places where he found the gelatin like under his stove and stuff in his brand new house that we did that in. So this helps avoid some of that because this is a super easy model to use. The authors in this study showed that it cost $3. It took 5 minutes to do, and Dr. Al's kitchen doesn't get dirty doing it. Very nice things, but you kind of need to know how to do it. So you open the gel. You literally take the gel out of the package and put straws in it to make the vessels, and then you submerge it halfway in water, and then you just be safe and have fun. So this is an example picture from the article that they used to show you how to do it. So basically this gel, it comes pre-packaged just like this. You literally push the straw all the way through to make the hole, and then you submerge it halfway, not all the way, you submerge it halfway in water so that the water fills the hole but doesn't cover the top portion of the gel. And it can be used, you can make 5 insertions is what they recommend in each of these gel packets, and you can get about 5 uses out of each one. So this is an example picture of how good the models look, right? What an appropriate model here to look at and identify this target. And they actually were able to show that you could get 25 IV sticks out of each area, so a total of 125 IV practices out of one piece of Kaniaku gel, so one $3 piece of gel that took 5 minutes to make. And if you imagine scales of economy, if you need to make 1,000 of these, you really only need to make 5 of them, which probably takes you 10 minutes and still costs you maybe $15. So a really great innovation. Some of the things about what's next to necessarily do with this, I'd like to see this compared maybe to some of the other kind of models that we have out there, whether that's, SPAM or ballistics gel or this really messy Metamucil gelatin thing that I promised to never do ever again. But one of the things that's interesting about this that they looked at in this kind of innovation paper is they looked at it lasted 7 days. So we tried to save our Metamucil and gelatin for the next year to use it the next year of residence. Bad idea. So that turns into just a moldy mess in your refrigerator. And I would be interested to know how long this lasts in a refrigerator. They did this both in water and in dry packaging, and they found that it lasted 7 days. I don't know if 7 days is a realistic, you can make it a week before when you're free and then use it later that week. But I'd be interested to know, does this last a couple months, a couple years, maybe not a couple years, it's not a Twinkie, but at least a year, so you could maybe use it the next year or the next 6-month cadre, or maybe when you have your students rotate, it's, you have them every month. Does it last a month or 2 months? That might be kind of interesting knowledge. And then, like I said, to compare it to some of the other ultrasound and maybe some of the more expensive models, because if we can show that it's equally as effective as a teaching tool, this would be something that people would be really interested in. So I'm going to pass this back to Dr. Russell.
Okay. Thank you. So that's it for the didactic. Hopefully you guys were able to learn some tips in terms of how to design your studies kind of moving forward. I do want to encourage everyone to come to the business meeting tomorrow to hear about all the SAMES award winners. And again, thank you to everyone who voted and everyone who's publishing ultrasound research out there. Does anyone have any questions? Please stand up and shout them out.
Thank you all for coming. I wanted to make a brief comment about RCTs. They are intimidating. Having done a few, they're incredibly hard work. I remember when I presented the SOAP1 trial, a friend came up afterwards and said, "Oh, I thought there were 30 institutions in in the SOAP consortium, and we did that study at 2. So only 2 out of the 30 were at a correct part of their adoption curve of using FAST. They couldn't be too low because then they wouldn't be using FAST effectively. It wouldn't be accepted by the team or the trauma surgeons. And they couldn't be too high on the curve, like Scalia down in Maryland, Shakarama, basically said, I can't randomize anybody not to get a FAST exam. So we had to find that sweet spot, which makes it really hard. And the study actually ended about 30 to 50 patients shy of our goal because after struggling to find people on the right part of the curve, I forgot to take into account that the institutions would continue up that adoption curve, and they both, after a year and a half, said, we can't randomize anymore. So research is hard. A comment about the consensus process, that's also hard. Nominal technique is good, it's quick. At WinFocus, we use the modified Delphi, which is multiple sessions of debate and voting, just finding consensus. You'd think, we're all here today because we're into POCUS and promoting academic activity in our area. It's unbelievably difficult. Even when the grading of the evidence is very high and numerous, there were times we couldn't find consensus. And then there were things where there was almost no evidence where everyone agreed on something. So it's hard. We started the session, somebody was talking about, Francis was talking about, our focus on making diagnoses, and that is the traditional way to look at this. But Alan Jones and others have looked at it from the opposite direction. Mainly, what is the level of clinical uncertainty when you're presented with someone in shock, and to what extent can POCUS mitigate clinical uncertainty? So the traditional approach to research is how accurate is it in making a diagnosis of X, but maybe we need to spend more time minimizing clinical uncertainty and proving to our colleagues that POCUS, this new thing that we've devoted a lot of time and energy to, it doesn't add to our cognitive load, it actually reduces it substantially. Thanks.
Thank you, Larry. Any other comments or questions?
How can people stay informed about all the good research stuff that AEUS is doing?
That sounds like a planted question.
Join AEUS, it's free. All right? Couldn't cost you a dime.
Yes, join AEUS. We have a lot of great resources on the website as well.